Hey there, my name is Jarrett Mitchell, and today we're going to be talking about reduction of GERD symptoms in infants under 1, a systematic review of strategies. And I am in Nursing 7220 at Valdosta State University, and our professor is Dr. Blankenship. So, GERD is actually a short acronym for gastroesophageal reflux disease. It occurs when the stomach acid is brought up or reflux from the stomach into the esophagus. This causes irritation and inflammation of the esophagus that can lead to ulceration and bleeding if not treated. GERD in infants is where you have the reflux disease in the newborn or infant population. It's a common pathology that's often treated with medications such as PPIs, which are proton pump inhibitors. You can also use other medications such as H2 blockers, but PPIs are kind of the more middle of the road treatment when it comes to pharmacologic therapy. These medications, while helpful, are not without side effects and risks associated with long-term use. Some side effects include diarrhea, nausea, vomiting, stomach pain, rash, headache, constipation, and increased flatulence. What you really worry about is long-term use of PPIs, such as omeprazole and pantoprazole, that can lead to kidney injury and chronic kidney disease. The goal of the pharmacologic therapy should be to correct the pathology causing the GERD and avoid any long-term pharmacologic therapy or progression to the need for surgical intervention. Newborns and infants are much more prone to having GERD symptoms, and this can be very scary for parents and for other people that don't know what exactly is happening. As APRNs, we're going to be in different settings. You could be in the pediatric setting, the primary care setting that sees pediatrics, and you could treat this pathology quite frequently. It's important that APRNs maintain the insight and up-to-date guidelines on practices regarding GERD treatment in the infant population if they are to be managing their care. So, what can be done to prevent GERD symptoms, or at least make them less intense and less frequent, that they don't start causing erosive pathology of the esophagus. The two main areas of treatment the two main areas are treatment and prevention. Treatment being medications, stuff like that, and then prevention can be stuff like positioning. After feedings, you trying to leave the infant upright for 30 minutes after feedings can help prevent the GERD. So intellectual curiosity begs the question, does treatment with medications or targeted change of lifestyle changes and feeding habits improve GERD symptoms in these infants one more over than the other over a 4-week time frame, which is our PICO question. One article that I researched was done by Jed Sherla et al. It was the role of feeding strategy bundled with acid suppressive therapy in infants. It was a randomized control trial. We used the JBI tool to critique the article. It actually analyzed PPI use solely versus concurrently with positioning techniques to see if there were any improvements in the GERD symptoms over a 5-week period. The sample size was total of 688 infants that were narrowed down to 75 after exclusion and inclusion criteria were initiated. There were 36 in the conventional group and 40 in the study group. The study group were the ones that had the positioning as well as the pharmacotherapy. They were using objective markers to monitor for the GERD symptoms. They were using pH impedance testing. They were also using a subjective questionnaire for parents of the kids. The findings concluded that the outcomes were really statistically insignificant when it came to the concurrent therapy of positioning and pharmacologic therapy. So this was also confirmed using the JBI tool. The study definitely had marked limitations such as small sample size, minimal intervention strategies, among other things. So when we go looking into implementing plans for the treatment and what we would do to implement a study or a treatment practice for treating GERD in infants, we look for clinical practice guidelines. And so this first set of practice guidelines were done by Rosen et al. It was a systematic review of several randomized control tests, and it was a retrospective meta-analysis. They they tested the pharmacologic versus the positioning, and after the analysis of data, they showed that the use of meds does slightly decrease the symptoms of crying and vomiting in infants with the GERD, but that the positional therapy does not have as much of a statistical improvement noted. The second practice guidelines that we reviewed were more so a review of literature and published using two different algorithms of treatment, one specifically for infants under 1 and then one for children over 1. It was more of a broad-based guideline that they weren't super specific. No defined sample size, and their guidelines were really limited because they didn't have any RCTs cited. But they did use credible databases such as the Cochrane database and CINAHL. They recommended a PPI diagnostic test to trial the effectiveness of the pharmacologic therapy and medication effect on each subject. And they did support the use of positioning therapy, but stated it is limited due to infants only being able to place a pie on their back due to suffocation guidelines from the American College of Pediatrics. So in comparison, the two clinical practice guidelines or protocols mentioned previously both have positive and negative attributes to help guide study design. The specificity to outcome is very important to help guide your practice guidelines and recommendations, but they can also limit the inclusivity of certain subjects. Broad-based guidelines can help to include a larger value of subjects, but often lack inclusive specificity to certain populations and outcomes. A well-balanced approach can be taken to ensure effective sampling and inclusivity data and validity or reliability of outcomes. So given the review of these previous guidelines, if I were to implement a study, I'd utilize more so the first protocol that was aimed at the different question approach and design my study to more broadly include all pharmacologic therapy versus all positioning therapy interventions, and I have a more inclusive sampling size as well. I would try to have a 5-week period of observation while interventions were monitored and be in a controlled setting such as the NICU or PICU and incorporate clinical personnel and educate them thoroughly to help ensure the validity and reliability of the data for collection. So going deeper into that, I would try to set it up to where babies in the NICU would undergo a weekly alteration of pharmacologic therapy versus non-pharmacological interventions and compare the two over the 5-week period and use a combination of both PPIs and H2 blockers and have them compare the control group that would use the positioning principles and lifestyle modifications such as elevation after meals and supine sleeping positions. Like I said, it happened in alternating weeks for 4 weeks, or 5 weeks, and monitor for regression or progression of improvement of symptoms and using a standardized screening tool. And I'd like to try to have at least 100 babies included in the very end sample size, given the inclusion-exclusion criteria. I'd like to use the study to be hospital-based and include clinicians from the NICU to be inclusive in the evidence-based practice process, and also to limit bias from parents in the home setting. Evaluation of symptoms using the standardized iGERD-A tool, which would be used for data collection, and then synthesize the data after the study was complete. Overall, there'd be very minimal risk to the infant because they're already receiving their treatment in a hospital setting, so they're already going to be at risk to stuff like nosocomial infections and other stuff like that. But there would also be no conflicts of interest that I would foresee. So in summation, overall, GERD in infants is a pathology that plagues many innocent babies and that has the potential to be improved by 3 major ways: positioning, lifestyle changes, and pharmacological interventions and also surgical interventions. The goal of treatment should be to start with the least invasive interventions and move to a more invasive intervention such as pharmacotherapy, prolonging them as long as possible without causing harm to the baby by delaying the needed intervention. And then the primary goal would be reduction in symptoms, which is reflective of reduction in irritation to the tissue, as they are generally directly correlated. So I appreciate your time, and these are my references. And you all have a great day. Thank you for listening.